Hello and welcome to Headline News in Neuroendocrine Tumors, or NETs. I'm Steve Highsmith. All through 2011, Oncology.TV has brought you up-to-date coverage of the latest abstracts presented at global Neuroendocrine Tumor Society meetings. Today, we will highlight several abstracts presented at the ESMO European Multidisciplinary Cancer Congress held in Stockholm, Sweden from the 23rd to 27th of September 2011. We spoke with Dr. Erik van Cutsem, who provided an update on survival and safety data from RADIANT-3. Thank you, Dr. van Cutsem, for joining us.
Thank you very much for having me for this interview, Steve.
Before we discuss your important update, please tell us what you feel were some of the highlights for neuroendocrine tumor research this year at ESMO.
ESMO was a very interesting meeting this year, and we saw many interesting data in GI cancer as well as in other cancers. But if you focus on GI cancer and then especially also neuroendocrine tumors, at this meeting in Stockholm we saw a consolidation and a further confirmation of the excellent data with biological targeted agents in the neuroendocrine tumors, and especially also we saw a presentation where there was an updated survival analysis presented of the RADIANT-3 trial. And one of, let's say, the weaker points in the past of the RADIANT-3 trial presentations was that people were saying, you need a bit longer term follow-up with updated survival data. And we've seen these data at this ESMO meeting. And they confirm indeed clearly the activity of everolimus in patients with pancreatic neuroendocrine tumors.
Doctor, in your abstract, updated survival and safety data from the RADIANT-3 Phase 3 trial were reported. Can you briefly review the rationale, study design, and population?
The RADIANT-3 trial was a trial in patients with metastatic pancreatic neuroendocrine tumors, the well-differentiated or moderately differentiated tumors. And in this trial, patients were randomized between everolimus at a dose of 10 milligrams per day plus best supportive care, or placebo plus best supportive care. It was a randomized trial. More than 400 patients were included in the trial in a one-to-one randomization. And in this study, the primary endpoint was to look at progression-free survival. And in the initial publication in the New England Journal of Medicine, we have published that there was a clear difference in favor of patients treated with everolimus for progression-free survival, with a clear improvement, a hazard ratio of around 0.4, which was clearly statistically significant, but also clinically relevant according to the initial presentation. In the study, patients in the placebo arm could be crossed over, and a large number of patients received everolimus after placebo. And this was clearly the reason why in the initial analysis there was no survival difference between the two arms, but because of the fact that many patients crossed over.
Dr. van Cutsem, did you report on the survival endpoint at ESMO?
What we did at this ESMO meeting is in the updated analysis with a much longer follow-up time. Now, we presented the survival data also, and there was a trend, no statistically significant difference, but there was a trend in also a longer overall survival for patients treated initially with everolimus compared to placebo. If you look in detail at the numbers, the patients treated with placebo had a median overall survival of 36.6 months. Patients treated with everolimus, the median survival was not yet reached at this time point. So, and that's interesting, and we feel that that's important because with this longer follow-up, these data confirm clearly the benefits of everolimus over best supportive care. Also, if you look at the updated progression-free survival, the median PFS for patients with everolimus was 11 months. For patients treated with placebo was 4.6 months. The hazard ratio was 0.35. This is clearly statistically significant also in favor of everolimus. So, in brief, clearly nice data with longer follow-up, waving away some of the comments or concerns that some of our colleagues expressed in the past.
With longer follow-up, were any new safety signals observed?
No, of course, it's also important that if we follow patients longer and on longer treatment, that we look at adverse events in detail. And the good news is that there were no new safety signals reported. That most treatment-related adverse events for everolimus were grade 1 or 2, and that they were manageable with proper planning, monitoring, and treatment in this trial.
Finally, do the updated data affect the conclusions of RADIANT-3?
The updated data reinforce the conclusions of RADIANT-3, already showing that everolimus is clearly active in patients with pancreatic neuroendocrine tumors. The updated results just reinforce the strength and the robustness of the RADIANT-3 trial.
So in conclusion, do you have any closing remarks or comments that you'd like to make?
The RADIANT-3 trial is an important trial. It's a pivotal trial. That's also the reason why the initial results were published in the New England Journal of Medicine. And now also with further follow-up, we clearly see that these data are robust. The RADIANT-3 trial is the largest randomized trial ever performed in patients with pancreatic neuroendocrine tumors. And it opens also a new era, for new trials of new generation, and sets really a new standard of care for patients with pancreatic neuroendocrine tumors.
Dr. Van Cutsem, thank you for taking the time to join us today.
Thank you very much for listening to us, and thank you also, Steve, for asking these important questions on this very relevant and pivotal clinical trial. It is the largest trial that was ever done in pancreatic neuroendocrine tumors, and therefore it's so important that we can report on this trial.
Dr. Eric Van Cutsem discussing the update on survival and safety data from RADIANT-3. We thank all of the experts who participated in this edition of Headline News in NETS. I'm Steve Highsmith. Be sure to watch coverage on the latest news in NETS right here on Oncology.TV.